Thank you. Thank you, Pat, for those kind words, and thank you for the invitation. It really is a great honor and pleasure to spend time with you again. So when we talk about trends in overweight and obesity, almost every report you see describes rising prevalence of overweight and obesity. And it seems the only innovation or a development in the reports is just different ways of graphically displaying this evidence. So this report from the NCD Global Risk Factor Collaboration describes rises in rates of obesity in men, women, girls, boys, in I think virtually every country where they collected data from. Here's the figure for boys. The panel on the left is from 1990, and on the right is from 2022. And the rates of obesity are demonstrated by the pink bars, and each spoke going around the wheel is a different country. I don't know why the rationale for the exact ordering of countries, but if you start at 12 o'clock, just after 12 o'clock on a clock face and go around, the first country is USA, and then New Zealand and Australia. And from about 12 o'clock to 3 o'clock, that's Western developed countries and Europe, and then South America in green. Along the bottom is Asia, Middle East, Polynesia, and then the upper quadrant on the left-hand side is Africa. So almost everywhere the rates of obesity are increasing. In young children, preschool, these are the similar report, but this from the WHO, published in 2010, describing the observed trends in overweight in young preschool-age children between 1990 and 2010. And then for that publication, they predicted the ongoing rise from 2010 to 2020. So in that backdrop, it was really quite striking that we collated data together with Sarah Masson and Wayne and other collaborators to describe several settings where the rates of overweight in this young age group are significantly declining. And you can see these start from around 2005 onwards, and they describe relative reductions in the prevalence of overweight of around 15% in New Zealand, that's 5% in the state of Victoria, Australia, 9% in Germany. And this publication in the BMJ described a modest decline of 3% in England, but just a couple of months later, the latest national data showed an ongoing reduction, and it's now 7% over that period. So these rates of decline fit this fourth and final conjectured stage of the obesity epidemic. You may be familiar with these categories of the obesity epidemic, in particular the difference between stage 2 and stage 3 is in stage 3 the lower socioeconomic groups have higher rates of obesity, whereas in stage 2 they have lower rates of overweight and obesity. But in this paper in 2019, they described the fourth and final stage as their hypothetical stage. And they said they found no conclusive evidence of a decline in overweight or obesity in any population. So I think we have collated really the first evidence of obesity decreasing. And I have to say, it seems to be restricted just to this very young age group, 3 to 5 years old. In England, we have very robust data from an annual national child measurement program that measures over 1 million children each year in schools. And in contrast to the 4 to 5 age group, in the older age group, age 10 to 11, there's a steady, ongoing, and even accelerating increase in the prevalence of overweight and obesity. And it seems to be confined to these, well, the few, but the very particularly high-income countries. And in our publication, we collated data also from South Africa. We didn't join we put them as dots rather than lines because they come from different surveys with different survey designs. But you can see that the prevalence of overweight, again, in this same age group, has accelerated even beyond the WHO predictions. So what seems to be underlying these encouraging trends in overweight? It's always challenging to be confidently identify the reasons for any secular trend. But we think that the reasons are multifactorial, and there have been many, many changes in the care and support of children in this young age group. There have been much, over this period, there's been much greater awareness of the concept of overweight in infancy and early childhood, and this has led to dietary and policy changes. So it was only in 2000 that we published really one of the first papers describing the infancy period as important, linking rapid weight gain in the first few months of life to the risk of overweight and obesity in later childhood. In the Swede study, even up to age 19, that faster weight gain in the first 6 months predicted higher fat mass at age 17. And this seems to be a highly reproducible finding in other cohorts all around the world. And there have been several, you can see there have been several systematic reviews in each of those finding significant and positive associations in almost all cohorts studied. And this awareness that even infants and young children are overweight has provided a new perspective. For long before that, known that formula-fed infants grow faster, put on more weight faster than breastfed infants. But this insight showed that this rapid weight gain isn't healthy. I think it was previously thought to be safer, faster weight gain being safer, but actually this highlighted this as being a disadvantage to health. And previously, growth charts based on UK children in North America have been largely based on formula-fed infants, because those are the majority of the population in those settings. And from 2006 onwards, the World Health Organization produced a new growth standard for early weight gain and growth. And this is based on children who are optimally fed, who are exclusively or predominantly breastfed. And if you use that lower trajectory of weight as your reference or as your standard, this much more clearly shows up the excessive weight gain of infants who are predominantly formula-fed. So those lines show the average weight curves of children in the UK ALSPAC cohort, a representative cohort in the UK. And moving from the previous UK charts to the WHO charts in blue, much more clearly shows up their excessive weight gain, not just in these median lines, but these charts are now implemented in handheld records or even digital records that each family can see. And it's raised questions about why children who are formula-fed have excessive nutrition and weight gain. And many formula milk producers, in their quest to show that their formula milk is more breast-like, have addressed this issue, both particularly in terms of composition, their protein content. Over this period, a handful of randomized controlled trials showed that formulas with lower protein contents lead to lower rates of weight gain This is BMI from birth to age 5, 72 months, and the lower protein content formula led to a trajectory of BMI that is much more closely aligned to breastfed infants. And actually now all formula are aligned to the lower protein contents. And there's been greater awareness of the prevalence of excess feeding, excess weight amongst government committees, government reports, such as our second report here, based on national surveys of diet and weight in infants and young children. And this awareness has also led to a larger number of early obesity prevention trials. I list some of the trials. Baby milk was a trial that we developed and ran in the UK to avoid excess formula milk volumes in children who are formula fed. Also Nourish, Insight, POI that we've heard of. The Top Child is an international collaboration coordinated by Louise Bauer's team in Sydney. Amazingly to me, I identified 87 eligible trials of interventions to prevent obesity from a very young age. And they've remarkably collected data from between 30 to 50 of those trials for individual participant data analysis. Beyond diet and nutrition, though, I think there are many other factors that have contributed to these encouraging changes in overweight in this young age group. And in our paper, we list these as broader structural determinants covering the environment, social changes, policy, as well as commercial. And just to focus on a couple of these, in all of these settings that we described have shown very significant reductions in the prevalence of maternal smoking, which Wayne and other investigators have shown is linked to the risk of overweight in the offspring. Alongside that, in this early preschool age, again, in all of these settings, have seen very substantial changes in how children are looked after. There's in all of these settings, there have been major national government investments in providing paid education and childcare. And you can see the dates where policies have been implemented, but over this period, there have been increasing investments, and the proportion of children moving from informal now into formal educational settings has substantially increased. And I think crucially, alongside that sort of provision of different environmental setting, has been the establishment of clear guidance on providing healthy food and physical activity in those settings. Of course, those educational policy changes are difficult to evaluate, but you can see from the UK data just the substantial effect that the COVID restrictions had. And I know that we've heard there are many lifestyle changes that happened during COVID, but one of the most striking was that these early educational settings were closed overnight and then reopened again. And you can see the impact that had on the trends in overweight. So just to summarize those trends, that part of the talk to date, I think these trends are encouraging. We think that the reasons are very likely to be multifactorial. And these efforts need to be maintained and strengthened. You can see from the spike during the COVID restrictions was really quite worrying in terms of how quickly these improvements can be reversed. Also, the prevalence of overweight is still very high, particularly in New Zealand. It's certainly still one of the highest, so much more needs to be done to continue those trends. And we need to make sure that these lessons learned need to be extended, adapted to many other settings where overweight seems to be still increasing, particularly in South Africa and other developing and transitioning countries. I just put on there the citation to this paper and list the co-authors there. But we can also think, though, from these findings, as I say, so far we've only seen them in this young preschool age group. But are there lessons we can identify, could make an impact on other age groups, other populations where this reduction hasn't been seen yet? So in terms of possible lessons for other settings, first is an optimism that these increasing trends aren't inevitable. And like Claire Ahmad, I'm an optimist. You might think it's maybe misguided to be optimistic based on such a few data points. But let me encourage you possibly not to be pessimistic, not to be nihilistic, that these trends in obesity can't be changed. I think that pessimism is very often a barrier to making any intervention, that thought that, oh, it's not worth it, that's not going to help. So I think that really we need to overcome that barrier. We need multifactorial changes. Now, of course, each component needs to be rigorously developed and evaluated, but to change trends at a population level, we probably need a multiplicity of different approaches. And then cynics might say, well, this very young age group, it's much easier to change. They're not deciding what they eat, what they do. They are a captive audience. And of course, that is true. But what we can learn from that, what we can generalize from that, is that maybe interventions that require low individual agency, less individual choice, buy-in, may be more effective. What I mean by individual agency, agency is about the individual choice based on free will, and the opposite is structural changes in the cultural, environmental space that influence our decisions. And my colleagues in Cambridge, Jean Adams and Martin White and others, have described that this difference between individual agency versus structural change may explain why some interventions are more effective than others. Just the example to help illustrate this is for how to increase the intakes of folic acid and status of folic acid in the population. Well, a low agency intervention, a structural intervention at the top, would be to fortify flour with folic acid. It's something that actually in the UK we've decided to do and will be implemented very soon. And that way, anyone who continues to use mainstream flour will receive that fortification. Conversely, a high individual agency approach would be to give information leaflets to people. That depends on people receiving that information, reading that, understanding it, making a change to take folic acid supplements, getting the supplements and then actually taking that. And then every step of that process, people will disengage and drop out. So overall, a structural approach is often more effective. And it doesn't mean that taking folic acid supplements is effective at improving folic acid levels, but intervention at the individual level may be less effective than an overall structural change. The other advantage of a structural approach is that it avoids the likelihood of blame. An individual agency approach can lead to a stigma or a blame on individuals then who are overweight, obese, that they haven't made that free will, that choice. Although a challenge of a structural approach is that this difference, unfortunately, has become very politicized. And right-wing governments tend to favor more agency, individual choice, whereas left-wing governments tend to support more structural approaches. And the right-wing governments say that these structural approaches are almost like a state control, and heard of the phrase nanny state. But I think this can change as we see the impact, the effectiveness of structural changes. Indeed, it was our conservative right-wing government who introduced, surprisingly to us, a UK soft drinks industry levy, which was essentially a tax on sugar-containing soft drinks. And there's accumulating evidence now of the benefits, of the effectiveness of this policy. There was a substantial reformulation of soft drinks to avoid that levy. There has been substantial reductions in the amount of sugar purchased and the amount of sugar consumed. There's a lower obesity prevalence, though it's unclear why that's only seen in girls and not in boys. Fewer children admitted to hospitals for dental extractions, asthma, improved health overall, no lasting financial effects on companies. And in relation to the previous discussion on the cost of prevention, these fiscal interventions have no direct cost to government, indeed may be revenue raising. So, we need more of these fiscal interventions to promote further reformulation. We need extension of certainly in the UK, of this approach to, it doesn't cover milk drinks, many of which are enhanced with sugar and flavorings, and to cover other foods high in free sugars. Other types of structural interventions, restrictions on marketing, price changes, and restrictions on the availability of unhealthy foods. In fact, in the UK, we have passed legislation to approve many of these changes. Unfortunately, with frequent changes of leadership, everything else has been shelved until 2025 or later. The other advantage of a structural approach is that, as my colleagues highlighted here, that they can be more equitable, as well as more effective. They can be more equitable. And you can see at every step of disengagement or dropout here, people from high-risk groups are more likely to disengage. And this is important, obviously, for obesity, which is so highly structured in the population. The prevalence of overweight and obesity is more than double in the most deprived households than it is in the least deprived. And indeed, in our review, in the BMJ, New Zealand was the only country which showed a narrowing of this socio-economic gap in the prevalence of overweight, and a narrowing whether you look by area deprivation, by ethnicity, having put here also the gap between urban and rural, and I'm sure that this is no coincidence to me. From my perspective, engaging with a Better Start over the last 10 years, I do think that New Zealand and a Better Start are world leading in engaging, co-developing and co-producing interventions covering all population groups. So often in the UK I see approaches which seem to be providing lip service, but I'm really appreciate also there's not just a fixed framework that you have of doing it. You're always looking for better ways to co-produce and engage all populations. And I took this from one of your reports, thinking of new ways, new ideas, I say, to better engage and better ensure the co-development of interventions. Just in the last couple of minutes, going to take a bit of a shift. So, my interest as an epidemiologist does fit with the population shift strategy to prevention. But as a clinician, seeing individual families and individual children, of course, there's also a need to think of individual-based approaches. And indeed, the epidemiologist Jeffrey Rose, in his preventive medicine treatise, describes that these are complementary. On the bottom panel, the population shift, but also the targeted high-risk approach. And we need to recognize that actually for overweight and obesity, there are very substantial inter-individual differences in the susceptibility to obesity. Much of this is genetics. You can see here that there's a substantial heritability, genetic component of to BMI across the age range, particularly higher in children than in adults. And it's not just genetics on on the one side and environment on the other side. These things do interact. And this paper by Claire Llewellyn in UCL shows that heritability of BMI is substantially higher in those households that have an obesogenic environment. So these factors do interact. Much of what we know about the genetics of obesity, it seems to largely work through the regulation of appetite, which is the drive to eat, and satiety, which is the feeling of fullness. And you're trying to characterize the range of appetite across populations. And so think of the high-risk individual approach has been certainly very valuably informed by the Better Start publications on prediction, early life prediction of obesity. And I'm not saying that we necessarily need to genotype everyone to add to that prediction, but if adding the mechanism of genetics, the appetitive traits, may further increase the predictive ability, but it also may help to shape the type of intervention given to people at high risk. So here's the further detail of our baby milk intervention, which reduced the volume of formula milk, ages from 2 to 4 months through to 6 to 7 months. This was the average intakes in the control in blue and the intervention group. But if we look, if this is an unpublished post hoc analysis, the intervention effect we saw was actually stronger in infants rated as having higher appetites. So here the control group is at the top, the intervention group is along the lower line, and so the difference between these lines is essentially the intervention effect, and you can see that effect is larger along the x-axis on children rated as having more food responsiveness, a sort of a measure of their appetite. And conversely, when we measure slowness of eating as a measure of satiety, again, the intervention effect was largest amongst children who had the lowest levels of satiety, again, the most food-seeking infants. And our intervention wasn't specifically tailored to do this. It was I have to say, it was an encouraging surprise to me. It was the same intervention given to all families, but it was very personalized. We encouraged parents to respond to the signals given by their children, and just qualitative evidence shows that the families who with hungry children, I guess, identify more with what we were trying to do. So, just to conclude, I think these trends are encouraging, if not to be optimistic. They are encouraging not to be pessimistic. I think there is encouragement in that there are many interventions that we can and should implement. And also I think there is interesting and exciting prospect for high-risk intervention, for not just identifying high-risk groups, but actually tailoring interventions to those groups. And just my final remarks, just to say how for me, it's been a huge honor and pleasure and education to be involved in the SAP of A Better Start over the last 10 years. So really, thank you very much for that, and thank you for your attention.